Today I want to unpack something that sounds simple on the surface but really isn't. Because depending on which report you read, you'll either feel reassured or deeply alarmed. If you skim the headlines, you'll see the familiar narrative. Young people are drinking less, smoking less. In many school surveys, reported drug use among 11 to 15-year-olds is lower than it was in the early 2000s. The phrase that often gets used is generation sensible. And on one level, that's accurate. But then you step into a different data set. You look at hospital admissions, you read coronial toxicology, you examine mortality statistics, and suddenly it feels like you're reading about a different country entirely. Record drug deaths in Scotland, persistently high mortality in England and Wales, polydrug toxicity, synthetic opioids emerging in supply chains, illicit benzodiazepines. So which version is true? The answer is both. But only if we understand who we are talking about and how we are counting. Let's start with something that often gets blurred in public debate. When people talk about the drug death crisis, there's sometimes an implicit assumption that young people are driving it. They aren't. If you look at the statistics properly, the highest drug-related death rates in the UK are not among teenagers. They are concentrated in older cohorts. In Scotland, mortality rates are highest in the 35 to 54 age range. In England and Wales, the pattern is similar. Middle-aged men, often in their late 30s, 40s and early 50s, carry the greatest burden. This is, in large part, the aging cohort effect of the 1990s and early 2000s heroin generation. Long-term opioid use, layered with benzos, alcohol, crack cocaine, physical ill health, mental ill health, and deprivation. The mortality crisis is aging. That doesn't mean younger people aren't experiencing harm. They are. But the harm profile looks different. Among younger groups, we're more likely to see acute toxicity, mental health presentations, neurological injury linked to nitrous oxide, and increasingly cases of ketamine-related uropathy, the correct clinical term for the chronic inflammatory bladder damage associated with sustained heavy ketamine use. In severe cases, this leads to ulceration, fibrosis, dramatically reduced bladder capacity, and sometimes reconstructive surgery. That's serious harm, but it is not, at present, the primary driver of national drug mortality statistics in the way opioid and polydrug deaths are among older adults. So already, we need to separate two narratives: prevalence among younger populations and mortality concentrated in older, more deprived cohorts. And then it gets more complicated. When I went looking for the single unified UK drug dataset, the one big national number, I found something important. It doesn't exist. We don't have a unified UK system. We have a patchwork of devolved data structures. In England, prevalence is largely drawn from the Crime Survey for England and Wales, which is a household survey, and from treatment presentations recorded through the National Drug Treatment Monitoring System. Scotland operates through the Scottish Health Survey and mortality data from National Records of Scotland. Northern Ireland has its own substance misuse database. Different surveys, different sampling frames, different methodologies. So when someone says, drug use in the UK is rising or drug use in the UK is falling, the first question should be, which dataset, which nation, which age band? Because we are often comparing apples, oranges, and pears and presenting them as one piece of fruit. Age boundaries are equally unstable. School surveys usually cover 11 to 15-year-olds. Household surveys begin at 16. Young people might mean 16 to 24, or sometimes 18 to 24. A 15-year-old is in one statistical universe. At 16, they move into another. A 17-year-old may suddenly be grouped with 24-year-olds who have been working for several years. Headlines merge these categories as if they are interchangeable. They're not. And then we have the hidden populations. To appear in the crime survey, you must live in what the Office for National Statistics calls a private household. That excludes young people who are homeless or sofa surfing, care leavers in unstable accommodation, those in young offender institutions or secure settings, pupils in pupil referral units, and children excluded from mainstream school. In other words, some of the highest risk groups are structurally undercounted. School-based surveys have similar blind spots. They're conducted in classrooms. But who isn't in class on a Tuesday morning? Persistent absentees, excluded pupils, young people already disengaged. So when we read that drug use among school children is down, what that often means is drug use among regularly attending mainstream pupils is down. That's more precise. It's also less comforting. Definitions blur things further. Ever used is not the same as dependent use. A 15-year-old who experimented once 6 months ago ticks the same box as someone using weekly if the measure is lifetime use. Public debate often collapses experimentation and entrenched harm into one category. Treatment data tell a very different story from prevalence surveys. Meanwhile, the drug market itself has changed. Cannabis potency has increased over time. Cocaine purity has risen compared with historical lows. Illicit benzodiazepines circulate in some regions with highly variable strength. Synthetic opioids such as nitazines have entered parts of the supply chain. Ketamine use has become more embedded in some student and nightlife settings. So here's the paradox. It is entirely possible that fewer young people overall are experimenting with drugs compared to 20 years ago, while a smaller, more marginalized group is experiencing higher intensity, higher potency, and more pharmacologically volatile use. At the same time, the bulk of drug-related deaths are occurring in older cohorts with long-standing dependency, complex trauma, physical ill health, and socioeconomic disadvantage. Overlay deprivation, and the picture sharpens further. Drug mortality risk is dramatically higher in the most deprived areas across the UK. Inequality is not background noise in this crisis, it is central to it. So when we talk about youth drug trends, we have to be precise. Are we discussing experimentation rates among 13-year-olds in mainstream schools? Are we talking about 19-year-old university students presenting with ketamine-related neuropathy? Or are we examining 45-year-old men with decades of opioid dependency and multiple comorbidities? Because those are fundamentally different populations with fundamentally different risk profiles. If we collapse them into one narrative, we design blunt policy. And there's one final question that keeps nagging at me. If drug markets are increasingly digital, if supply chains adapt rapidly and dealers use social media platforms to target vulnerable individuals, why are we still relying so heavily on annual analog surveys to understand what is happening? Are we trying to navigate a dynamic digital drug economy with paper maps updated once a year? The mortality crisis is aging. The youth harm profile is evolving. Prevalence is not the same as severity. And what isn't counted can matter just as much as what is. So the next time you see a headline about youth drug trends being up or down, pause. Ask who was counted. Ask who was excluded. Ask which age band, which boundary, which definition. Because once you look properly at the data, not just the headline, the story becomes less simplistic, but it also becomes far more useful.